Hello guys, today we are going to talk about the breast surgery. In this chapter I am going to tell about basic anatomy, the importance of the lymph nodes and when to remove and when not to remove the lymph nodes. Also various type of breast surgeries. I am going to explain as simple as I can. I am also a medical student, so let's start. So breast is a modified sweat gland, as you all know. It is a modified sweat gland, right? So first we will talk about the anatomy. In the anatomy, we will read about the first of all we will read about the surface anatomy. So in the surface anatomy, the ribs, the bulk of the ribs are from second to sixth rib, all right, and from sternum to anterior axillary fold, all right. But as you all know, breast can be different in sizes, so it can extend till superficial. It can superiorly it can extend till clavicle, inferiorly till eighth rib. Please note eighth rib. And laterally it can extend lateral border of latissimus dorsi. Alright, so this is the basic surface anatomy. So actually the breast lies on the pectoralis major muscle. So here is the drawing, the basic drawing. This is the pectoralis major muscle, alright, and above the pectoralis major muscle there is pectoralis fascia, alright, and on the pectoralis fascia there lies our breast. Here are the breast, alright, and this is the nipple area, and this area is called nipple and the areola is called nipple areola complex, alright. So we are continuing the basic anatomy. How breasts are attached to the fascia is through the ligament of Cooper. Take note guys, ligament of Cooper start from the fascia and ends to the skin, alright. Here are the ligament of Cooper, okay, alright. So it is the muscle, pectoralis major muscle. This is the pectoralis fascia. This is the ligament of Cooper, alright. And also all the ducts from various part of the breast comes to the nipple, alright. How many ducts are there? The number of ducts are 15 to 20 ducts called lactiferous ducts, alright. So this is the basic anatomy, and now we will read about the lymphatic drainage, because in cancer or in surgery the actual important things are the lymph nodes, because if there is metastasis, if we remove the lymph node there will be no metastasis. And if we actually there are some surgeries where we need to remove the lymph node and where we don't remove, so we will read about that later. I'll come to that. So lymphatic drainage, alright. So there are two type of lymphatic drainage. One is axillary lymphatic drainage, alright. Other one is internal memory, alright. The axillary drainage is 80 to 90%, so we will talk about it. It's only 10%. Okay, the axillary is divided into two parts. The first one is clinical, the second one is surgical, alright. Obviously we will read about the surgical one. because clinical you will read about the clinical ones in the medicine, but I'll just tell you what are the types: anterior, central, apical, lateral, and posterior group lymph node. Alright, sorry for the writing. In the surgical division, the basic thing you should understand is, in the surgical division, the lymph nodes are divided by the pectoralis major muscle. Alright, I'm sorry, pectoralis minor muscle. So here is the pectoralis minor muscle. Alright, so the lymph node lateral to the pectoralis minor muscle are type 1. The lymph nodes which are medial to the pectoralis minor muscle are the third type, and the lymph node lies on the pectoralis muscle, it's type 2. Alright, so there are three type of lymph nodes in the surgical part. So this is pectoralis minor muscle. Alright, this lymph nodes also called rotor lymph node. Right, take note for that. So now we will understand about the surgical method for the breast. So if anyone comes to you with a lump in the breast or any problem with the breast, we'll start with the triple assessment. Alright, triple assessment. So in the triple assessment there are three things. The first one is, obviously we will take history and PE, then we will do the radiologic examination, and then we will do the histopathologic test. Alright, so in the history and physical examination, as you all know, the best method for history and physical examination is when we check for the breast clockwise and anti-clockwise. Alright, this is also called dial clock method. Take note, dial clock method. Okay, then in the radiology there can be two things. The basic thing we do on radiology is MRI, because MRI is the investigation of choice for the breast lump. But there is two things. We can also go for the radiologic X-ray. When we do X-ray or when we do USG and when we do mammography, X-ray is not much useful. So the next one is USG. So when to do USG and when to do mammography. So if a patient is less than 40 years old, we will go for the USG, and if a patient which is more than 40 years old, we will go for the mammography. Alright, why we do that? Because less than 40-year-old female has dense breast. Alright, dense breast. So when we do mammography on a dense breast female, we can found multiple nodules, and we cannot differentiate into a nodule and a normal breast mass. Alright, normal breast, dense breast mass and a nodule we cannot differentiate. After 40 years of age, there is no dense mass in the breast, so we can go for the mammography. Right, now we'll talk about them. The first one is ultrasound. Alright, so this is the best investigation to differentiate solid versus cystic lump or tumor. Okay, this is the investigation of choice in the pregnant woman with a breast lump. Alright, this is the question, and it is, as you already know, done less than 40 years of age. Okay, but as you know, USG is operator dependent. It depends on the person who do it. So this is the disadvantage, because it can give you false results. Next we will read about the MRI. Okay, MRI is the investigation of choice to detect, as I already told you, right? This is the best imaging to identify the local recurrence after surgery, also to identify local recurrence. And also, if USG is suspected to be false, then we can go for the MRI, right? So what are the, now this is the basic choices we have already read. The third one is histopathologic test. So in the histopathological test, the first one we do is fine needle aspiration cytology. Alright, fine needle aspiration cytology. The second one is FNMAC. Alright, fine needle non-aspiration cytology. So there are some drawbacks of FNAC. What are the drawbacks? The first one is we cannot differentiate between invasive and in situ cancer. Alright, we don't know if the cancer is in situ or it is invasive, so we cannot differentiate. The second one, the FNAC, we don't know the status of ER, HER2, new. Alright, these are the receptors I will tell about later, just be with me. And there is very high false negative rate. Okay, so in the histopathologic thing, the investigation of choice is true cut biopsy. Alright, which is incisional. So we take an incision, we do an incision, and then we remove the tissue from there, and then we study that. Alright, and if they ask you a question about the gold standard, it's excisional biopsy. Okay, so guys, what are the difference between investigation of choice and a gold standard? If you are asking about a gold standard, the gold standard is a thing, if you do that procedure, there is 100% chance that you will find out if it's a tumor or not. In investigation of choice, it's not about the percentage, but it will tell you about the tumor. Okay, so we read about the triple assessment. Now we will go for the breast surgery. Right, so we have already covered as you know, we have already covered the anatomy and the lymphatic drainage. Also we have covered the triple assessment. Now we will talk about the breast surgery. But before breast surgery, I want to talk about some receptors. Okay, so for the receptor thing, look, if there are, our body is formed in a way that there are some receptors in each cells, okay, which can be present at certain times. So in the surgical In the breast surgery, there are some receptors present on the breast tumor. The receptors are as follows: ER, alright, PR, HER2/neu. Okay, so there are 3 receptors which can be present. Right, we will talk about them later. But the basic thing you should know before starting the breast surgery, that there are some receptors: ER, PR, and HER2/neu. Right, sorry, it's HER2/neu receptor. Right. So what are the risk factors for the breast surgery? What are the risk factors for the breast tumor? Okay, breast cancer. So risk factor for the breast cancer is, the first one is age, obviously age, high age. Okay, early menarche. Don't worry guys, I will tell you about a trick to remember this. The third one is late menopause. And the fourth one is nullipara. Alright, so fifth one is obesity. Sixth one is alcohol. The seventh one is family history. Right. So how can we remember the risk factor? Just remember a basic thing: the breast tumor is associated with the estrogen exposure. Alright, sorry guys, breast tumor is depends on estrogen hormone, right? Exposure. So the more is estrogen hormone exposure, the more is chance of tumor. Okay, so it's proportional. So now we will correlate that with the risk factor. Early menarche means if a girl start menstruating before 14, 13, 12 year old, so she start menstruating early, so there is high chance of will be more time for there to express the estrogen. Also in the late menopause, like if a woman is getting menopause to 50-year-old, so there is at least 10 more years she is getting exposed to the estrogen. Then nullipara, whenever a girl is when a female is pregnant, until she is pregnant till 9 months, the hormone which is high in the blood is progesterone, and there will be low estrogen. Okay, so the more time female will be pregnant, there will be less exposure to estrogen. So a nullipara will have more exposure to estrogen. Obesity also, because there is conversion of estrogen, peripheral conversion of the estrogen, and also alcohol and family history. Okay, and also hormone replacement therapy increases the risk, but oral contraceptive pills do not increase the risk. Okay, hormone therapy increases the risk. Also, as you all know, radiation therapy increases the risk. Alright, and as you all know, until the female breastfeed the baby, there is less exposure to estrogen. So breastfeeding is protective and should be done till 1 year. Right. So now we will read about some pathology. Okay, so breast cancer. Here are the pathology of the breast cancer. So breast cancer can be of two types: sporadic or familial. Sporadic mostly 10% familial. Okay, And the gene that is affected in the breast cancer, the most common is p53. Okay, and in familial one it's BRCA1. Alright, BRCA1 and overall p53. Alright, so now we will talk about the BRCA gene. Alright, BRCA gene can be of two types, BRCA1 and BRCA2. BRCA1 present at 17q chromosome, the second one is present on 13q chromosome. Okay, so we'll compare. There is high risk in the BRCA1, there is not high but some risk of ovarian cancer is also high, but there is very high risk in the BRCA2 for the ovarian cancer. This is for the breast cancer. Alright, so now BRCA mutation predispose to the always remember BRCA mutation predispose the patient to hereditary breast and ovarian cancer syndrome. Alright, so there is recommended that they do the first degree relative screening. If there is BRCA mutation present, do the MRI at 25 year of the age. Okay, stop smoking, stop alcohol, regular exercise and lifestyle changes can reduce the risk. Also, for the risk reduction techniques, we can do the bilateral prophylactic mastectomy as done by the Angelina Jolie. It lowers the risk at 95%. Okay, we can also go for the bilateral salpingo-oophorectomy. It lowers the risk of ovarian cancer 90%. Tamoxifen is also given, which lowers the risk 47%. Alright, so now we will read about the invasive lobular cancer. Right, sorry, now we will read about the breast cancer in detail. We'll read about the receptor first. Alright, so if we do the immunohistochemistry, then we will find there is two types of receptor. The first one is ERPR receptor, the second one is HER2/neu, as I already told you. Alright, ERPR estrogen receptor, progesterone receptor. Okay, so this is estrogen, this is progesterone receptor. Alright, so ERPR, these are the nuclear receptor. Okay, this find in the nucleus, and HER2/neu is present in the membrane. So when we do the histochemistry, we see a cell, this is the nucleus. If the staining, methylene blue staining is done inside the nucleus, the most of the stain is in the nucleus, so these are ERPR positive. Okay, and if the methylene blue is in the periphery in the membrane, it's HER2/neu positive. Alright, so we can find this with the immunohistochemistry. Alright, now we will read about the Tnm staging. Alright, Tnm staging, definitely there is T, there is N, there is M. Okay, T means tumor, N means lymph node, nodal, M for metastatic. Alright, so T is divided into T0, no tumor, TIS, tumor in situ. Alright, T1, Remember, T1 if the tumor is less than or equal to 2 centimeter, right? T2 more than 2 centimeter but less than or equal to 5 centimeter, and T3 into more than 5 centimeter. T4 we can divide if into 4 parts. Okay, T4A, T4B, T4C, T4D. T4A is involvement of the chest wall. T4B involvement of the skin. T4C if A plus B is present, right? And T4D is inflammatory if there is inflammatory process. Okay, all right. So this one has the worst prognosis. Keep in mind, all right. This one has the worst prognosis. For the N staging, as you already know, N0 is no lymph node involvement, N1 is only mobile axillary node involvement, N2 type A and type B. Type A if lymph node is fixed, type B internal memory lymph node is positive, alright. N3 divided into 3 parts, A, B and C. A is infra clavicular, the second one is internal memory plus axillary lymph node positive, the C1 is supraclavicular. Okay, so when you will palpable for the supraclavicular lymph node, you can palpate the supraclavicular lymph node. So there is involvement of supraclavicular lymph node, shows us the N3 type. In metastasis, the M is M0 and M1. M0 no metastatic, and M1 there is metastasis. All right. So for the surgery type, there are 2 types of surgery in the breast cancer. First of all, breast conservation type surgery. Second one is mastectomy or breast removal surgery, right? Keep in mind the overall survival rate is same in both, right? So survival rate is same in both. If you do a breast conservation or mastectomy, it's same to have overall survival, right? So first one is breast conservation surgery. So we will only remove the limb, all right? Only limb removement. We will only remove the limb, all right? So it also called the lumpectomy, all right? Lumpectomy. Whenever we do a lumpectomy, we take margin of 1 mm, right? 1 millimeter margin, right? What are the contraindications for the breast conservation surgery? The absolute one is pregnancy. If a woman is pregnant, we cannot go for the breast conservation surgery, all right? Actually, we can do the lumpectomy, but whenever we do breast conservation surgery, we have to give the radiotherapy afterward. Okay, after breast conservation therapy, we have to give radiotherapy, but radiotherapy cannot be given to pregnant women. So it's an absolute contraindication to do BCS, right? And relative contraindications are collagen vascular disease, like SLE or RA, or prior radiotherapy to chest wall. Alright, now we completed the breast conservation technique, the therapy, breast conservation tumor surgery. Now we will lead on the mastectomy. Mastectomy or removal of the breast can be of three types. First one is radical, second one is modified, third one is simple. Okay, in the radical, what we do in radical, we remove the breast plus NEC, as I already told you, nipple areola complex, also pectoralis major muscle and minor muscle, and level 1, 2, 3 and axillary lymph node. Alright, this is called the radical. Modified breast surgery, or we can also call it modified radical mastectomy. In this, we remove breast, nipple areola complex, pectoralis fascia, alright, level 1, 2, 3 axillary lymph node, or pectoralis minor muscle if you want, so it's plus or minus. Alright, third one is the simple one. We remove breast, nipple areola complex, pectoralis fascia, right, but lymph node are not removed. Alright, indications: DCIS, fungating lesion or phylloid tumor. We'll talk about them later. What are the complications in the surgery? What are the complications for the surgery? The first one is hemorrhage. The second one is there can be a nerve injury. The most common nerve injured when we are doing the breast surgery is intercostobranchial nerve. Alright, intercostobranchial nerve, ICBN. What it does, it sends supply to the axilla. So after surgery, a patient can come to you with altered sensorium in the axilla, in the underarm. Right, also there is flap necrosis. When we do the surgery, we open the breast, so there can be flap necrosis, and the most common complication is Serum of Formation. This is the most common complication, Serum of Formation. Alright, what is Serum of Formation? Serum of Formation is accumulation of the fluid beneath the flap. Alright, so what we have to do, if there is Serum of Formation, we have to drain. Alright, so we have to drain alright. If drains are removed and still there is Serum of Formation, we can do the aspiration under aseptic condition. Alright, or then we can do the pressure dressing. There can be lymphedema because after mastectomy, when we have already removed the lymph nodes, so there can be a lymphatic blockage in the arm. Alright, and there can be swelling of the arm. Okay, there is 2 to 10% risk of the lymphedema. So the fifth one is lymphedema, alright, called swelling of the arm secondary to lymphatic blockage. There is 2 to 10% risk, alright, and long standing lymphedema. If it's long standing, then it's called Stewart Travis syndrome, right? There can be risk of local recurrence, alright. For the local recurrence, we will do the MRI. There can be phantom breast syndrome. So guys, what is phantom breast syndrome? This is the most common cause of intercostobranchial nerve neuralgia, right? So intercostobranchial nerve neuralgia is called phantom breast syndrome, right? So guys, I want to talk about sentinel lymph nodes. What are the sentinel lymph nodes? Sentinel lymph nodes are the first drainage lymph node from the cancer, alright. This was found by the surgeon Cabana in the penile cancer, alright. It can also be present in the breast, malignant melanoma cancer, vulvar cancer, head and neck cancer, and obviously penile cancer, alright. So there are different techniques to identify the sentinel lymph nodes. We will not talk about them. It's very complicated thing, alright. So now we'll read about the chemotherapy. This is the surgery. Now we'll read about the chemotherapy in the breast surgery. For the chemo, what are the indication for the chemo? Sorry guys for the handwriting. What are the indication for the chemo? If there is positive lymph node, the first one, if there is positive lymph node. Second one, triple negative BC and HER2 positive tumor, right? In HER2 positive tumor, we give chemo plus herceptin. It is also called trastuzumab. This is a monoclonal antibody given for 1 year, alright. When we give the chemo, if the tumor is less than 1 centimeter, alright, and also given in locally advanced breast cancer. So what is the chemo regimen? The latest chemo regimen is AC or EC followed by 40. So what is this? AC or EC? AC or EC. A is adriamycin, C is cyclophosphamide, right? E is epirubicin, alright. So we give either AC or EC, alright. We give either AC or either EC followed by 40. 40 is Texans, alright. So for AC, 40 Texans like paclitaxel or docetaxel, alright. But there is a chance of neuropathy. This is the side effect of the Texans. So alright, so this one was the latest management of chemo. So now we'll read about the radiotherapy. What are the indication for the radio? Indication for the radiotherapy, we can give, as I already told you, radio post breast conservation surgery. If there is positive lymph node, we can give radio. If there is locally advanced breast cancer, we can give radio. If the tumor size is more than 5 centimeter, we can give radio, right? Now we will read about the hormonal therapy. Hormonal therapy is given only if the tumor is estrogen receptor or progesterone receptor positive. Okay, there can be two type of hormone therapy: premenopausal or postmenopausal. Premenopausal, we give tamoxifen. Alright, if premenopausal, we give tamoxifen. If postmenopausal, we give aromatase inhibitor. Like letrozole, anastrozole for 5 years, but now we can give till 10 years. Alright, tamoxifen also can be given for 10 years now. Side effects, obviously, as you know, side effects are as similar as we can look in the postmenopausal woman. The side effect is hot flushes. Actually, this is the most common side effect, hot flushes. There can be endometrial hyperplasia. Alright, so we have already talked about the different type of therapies we can give in the tumor. Alright, so now we will read about the different type of cancer, and then we will apply the things we have read before. Right, so the first one is early breast cancer. In early breast cancer, what we do surgery. We can give breast conservation surgery. Can also go for the sentinel lymph node biopsy. Alright, if BCS is contraindicated, we can go for the mastectomy. Alright, like in pregnant women, we cannot do the breast conservation surgery, so we can go for the mastectomy. In chemo, we can give, as I already told you. Alright, if there is T1 T2 staging, N0 M0, we can go for the chemotherapy. Alright, and if the tumor is ER, PR positive or negative, we can do the molecular test. Alright, in radio, if lymph node positive, and after breast conservation surgery, we can give the radio. Can also give the hormonal therapy. Alright, so radio is you also know, or ST can be given. Alright, if there is locally advanced breast cancer, I have already told you, we can say if it's locally advanced, if it's T3N1 M0 or any T4, any T2, any N2, I'm sorry, any T4, any N2 or any N3 with M0. So guys, M0 is constant. If there is N1, N2, N3, N4 with only T3, we can go for the locally advanced breast cancer therapy. So first, because the tumor is already advanced, so first we will give neoadjuvant chemo. Neoadjuvant chemo is given before surgery to shrink the tumor. Then we can go for the, after chemo we can go for the modified radical mastectomy, and then we can give the radiotherapy. Alright, if the tumor is HER2 new positive, we can give Herceptin. Alright, if ER/PR positive, we can go for the hormonal therapy. Alright, the third one is metastatic breast cancer. Alright, if the cancer is metastatic, we can give palliative treatment. We can give palliative treatment. The palliative treatment can be given if in two types. The first one, if ER/PR positive, ER/PR negative. Alright, if ER/PR positive, we can give hormonal therapy. If negative, we can give directly chemo. In chemo, we can give trastuzumab, pertuzumab, palbociclib. Alright, keep in mind, if first we will give hormone therapy. If there is resistance to the hormone therapy, then we can give chemo. Alright, so here this thing ends. Thank you.